Bismillah ar-Rahman ar-Rahim. This presentation is about patient safety, and this is Dr. Muhammad Farid Tabib. Focus on a very important two facts before starting the presentation. Fact number one is to err is human, which is a concept by Institute of Medicine in the early 2000s. And the second one is error in healthcare can kill more than RTA, road traffic accidents, cancers, and AIDS together. It's again a study in United States. I think also it's 1999 or around. It's not new concept, but we have a history for this concept by our Prophet Muhammad sallallahu alaihi wasallam. We are talking about 1400 years from now, or even more. He's saying that كل بني or كل ابن آدم خطاء وخير الخطائين التوابون. So everyone is liable to do mistakes, but the best is or who going back and do tawbah, or he will resign from the sin. So this is our start for this presentation. Let's go now to the patient safety. Can you imagine that this tag could be on some hostels, that this hostel could be hazardous to your health? Could you imagine that it's the reputation of your hostel, that mistakes can happen inside this hostel because they are not committing with the patient safety? So it's hazard to your health to go to this hostel or to receive services in this hostel. What are the principles for quality healthcare service? If you want to provide patients with a qualified or a good healthcare service, you have to remember those concepts or principles. Your services should be safe, timely, effective, efficient, equitable, and it's patient-centered. If every single service you are introducing to patient, you kept in your mind that you have to ensure those 6 principles, it would be a very good healthcare or high quality healthcare services. We mention it in a very shortcut word. It's STEEP, S-T-E-E-P. So our main focus tonight is about the first one, is to give a safe healthcare services. So let's define patient safety or safety at the start. Safety is defined as avoiding both short-term and long-term harm to people resulting from unsafe acts and preventable adverse events. So if you are trying to avoid both short and long-term hazards or unsafe acts to the patients or to the people inside the facility, you are trying to keep or enhancing the safety. There is another definition which is done by Institute of Medicine. They define the patient safety as freedom from accidental injury caused by medical care. So now we know what is safety. So let's go for the main concept tonight, which is the International Patient Safety Goals, which were established by International Patient Safety Center at early 2005. They established that if you are committing with those international patient safety goals, you can enhance the patient safety inside your department. They are 6 goals, and the 6 goals are in sequence. Sorry. So goal 1, then 2, then 3, until we are reaching 6. Let's enumerate them at start before going for the detail. Number 1, identify patients correctly, or correct patient identification, as you wish. Number 2, improve effective communication, of course, among healthcare giver inside the healthcare facility. 3, improve the safety of high alert medications. 4, ensure correct site, correct procedure, correct patient surgery, or prevent the wrong site, wrong procedure, wrong patient surgery. Number 5, reduce the risk of healthcare associated infection. And at last, number 6, goal number 6 is reduce the risk of patient harm resulting from falls. Those are the 6 international patient safety goals. Almost all healthcare facility should commit with them, should implement them, should focus on them, and should monitor them. And even if there is results for the monitoring needs improvement, they have to improve them. That time they have a good patient safety culture and the implementation inside the healthcare facility. Let's discuss them one by one in detail. Goal number 1, identify patients correctly. So use at least 2 identifiers when you are identifying any patient while providing treatment or procedure or administering medication, blood products, or when collecting blood sample and or specimen from clinical testing. Now you are going to consult patient, identify your patient. You're going to do a procedure for the patient, you have to identify your patient. You're taking or administrating patient any blood or blood products or medications, you have to identify your patient. So you have to tell this is my correct patient to ensure that you are doing the procedure or the maneuver to the correct patient, not to another patient. Always use 2 identifiers at least. We have to mention at least. You can add more, but at least we are using 2 identifiers. The best is the full name and the medical record number. Some people will add ID number and anything else, it's okay. But at least we have to use 2 identifiers. Most important of them is the full patient name and medical record number. This is, as you know, in almost all healthcare facility, we call this one a wristband, identification band. As you see here, it's implemented in all over the countries here. It's implemented in Europe, United States, everywhere. As you see here, a lot of information. The most important is in the dark, highlighted in the dark color, which is the name and the medical record number or the patient ID. Okay, the patient room and bed number should never be used because we can confuse between them. Don't tell the nurse or don't tell a physician or someone to go to do something to a patient on bed 5 or in room 6, because simply patient can move from one hostel, from one room to one room, or from one bed to another bed. Sometimes some patient will go, for example, to bathroom and another patient will sit on his bed, or a visitor or another staff. So do not use the patient room number or the bed number as a patient identifier. Again, we have to label all containers we are using for whatever. We are using for blood or urine or stool or whatever. We have to put a label on them. And this label should contain, again, at least patient full name and medical record number. Most important thing in here now is you have to make the patient participating actively in his identification. Do not ask the patient ever, you are that patient. Don't tell the patient, you're Adam Muhammad Ali, you're Muhammad Ahmad Musa. No, you have to ask the patient, what is your name? Let him tell yourself what's his name. Do not estimate the name. Do not tell the patient your name is like this, like this, like this, because a lot of things or a lot of causes. Number one, maybe he is not the patient and he's pretending to be the patient to take the service or the medication. Number two, maybe your patient is under analgesia or something and he's confused. He's not knowing who's himself. So he can tell or nodding by his head that yes, and he's not the patient. So always make the patient actively participate. Actively participate means he have to state his name, not nodding or answering by yes or no. So now we have to use two patient identifier. We will label all container. We will actively making the patient actively participate in patient identification, and always we are doing all of this and put a wristband for every patient inside our hostel. Now we are implementing goal number one, which is identify patient correctly. So those specimens are not good because there is no label, no name, no medical record number over it. And also for blood and blood products, it's the Let's go now to goal number 2, which is improve effective communication among health caregivers. We have 4 things here in this one. To improve the effective communication between the health caregiver, we have to implement 4 things. But before, I have to tell you that almost all studies show that a huge number, a very big number of mistakes and errors related to patient safety inside healthcare facilities is because of this goal. People are not implementing it in a good way, so a lot of errors happening because we are not committing with the effective communication among health caregivers. How we can do it, as I told you before, 4 things we have to do in our hospitals or our healthcare institutes. Number 1, telephone and verbal orders. Sometimes the health caregiver is not available or we are in emergency condition, we cannot make an order, written order, and then the nurse read it and then she will implement it. We do not have a time. So we can give a verbal order or a telephone order if we are not available. If someone, for example, is in OR and sometimes someone is talking to the physician what we are going to do for him, so we can use the telephone. Okay, so telephone and the verbal order should be used only in emergencies or unavailable physician or unavailable health caregiver. What we have to do to implement it in a proper way, we have to follow write down, read back confirmation, and witness if possible. How come we will do it? Let's imagine now one scenario. The nurse is in ward and the physician, is in OR, and she have a patient complaining of severe pain. So she have to call the physician in OR and saying, "Sir, my patient or your patient, full name, medical record number is complaining of severe abdominal pain. What I can do until you will come?" Another scenario, patient arrived to ER. He is in a road traffic accident, a lot of bleeding, and the physician is ordering the nurse to give some medication. Patient have arrest, and he is ordered to give, for example, adrenaline or epinephrine. The nurse shouldn't say, "No, sir, you have to write first an order to me in a physician order," and something like this. She have to implement it because it's an emergency. We are saving life or a limb. That time she have to implement, then we have to document. So what we have to write, if the physician is not available in OR, we have to write down what he's saying. For example, he said that give the patient Buscopan or metoclopramide for vomiting, IV, 2 ml IV. The nurse should write down the physician order. Then she have to read or repeat back to make sure that she understand and she heard well. She have to tell, "Sir, do you mean that I have to give patient?" She mentioned the name. His medical record number is like this. He have, for example, he had appendectomy yesterday. I have to give him Buscopan 2 ml IV right now. This is the read back or repeat back. If he said yes, it's done. If she have another health caregiver beside her, he have to ask him to become a witness, and she put the physician on a microphone so both can hear himself. Then he have to sign this physician order within 24 hours of the order. What are the types of problems that can be reported from the telephone and the verbal order? Wrong drug. It's mistaken because it's very close pronunciation, like Celebrex, Cerebrex. Celebrex is NSAIDs, an non-steroidal anti-inflammatory drug. It's a painkiller, but Cerebrex is a cerebral stimulant, as I know. So it could be mistaken, so the nurse have to repeat back for the physician to make sure he mentioned this medication or this medication. another very important thing, which is a wrong dose. Always 15 is mistaken with 50. So what we have to do, we have to repeat back and focusing on the most important letter that can give or become the cause of the mistake. I'll give you one example now. This one, very, very important thing. 50 is mistaken with 15, so the physician or the nurse, when she's making sure that she have to tell, sir, do you mean 50 or 15? It's 50, 50, or it's 15, 15. Another thing, or another example, if S, which can be mistaken with X, they have to communicate and say S as in Sam or X as in X-ray. So number one in the effective communication is and the verbal order. B, another way for effective communication to be enhanced is we have to commit inside our healthcare facility with approved abbreviation, and we have to forget about, don't use, prohibited use of the prohibited list of abbreviation. So we have to have 2 lists of abbreviations. It's done by a committee, and it's have to be approved by hospital admin and should be updated at least annually. And we have to commit with the approved list and forget about the prohibited list of abbreviation. I'll offer you now a few names of the prohibited abbreviation list and the approved abbreviation list. This is a small type or a small number of the prohibited abbreviation. I'll give you only 1 or 2 examples. Number 1, we will never say give the patient 2 cc Voltaren, for example, because cc could be mistaken with units. So what we have to say, give the patient 2 ml. So 2 ml instead of cc. Number 2, we will never say give the patient 2 IU insulin or 10 IU insulin or 14 IU insulin, because if the physician is typing the order fastly, the U could be mistaken with V or could be mistaken with 0. So if it's mistaken with V, it could be IV. Instead of IU, it could be IV. If it's mistaken with 0, the U, it could be 10. So we will never use or write IU, we will write units or international units. We will not write IU. So please replace IU with units. Again, microgram, it could be mistaken with milligram. So we have not to write UG or MG. We will write MCG for microgram. Again, OD, we will never write a medication OD. ODs, it's of course taken for once daily, but it could be mistaken with something else like ocular drop. So we have to write daily and so on. This is the approved list of abbreviation. It should be approved by multidisciplinary committee, should be signed by them, and it should be updated annually. The other list is the list of approved abbreviation. It's something in our hostel we have to commit with. All of us know what is. I'll give you a few examples again. H/O means history. So all of the hostel, when they show or see H/O, this means history. NSAIDs, it's abbreviation for non-steroidal anti-inflammatory drugs. O2 is an abbreviation for oxygen. HTN is abbreviation for hypertension. ICU is abbreviation for intensive care units, and so on. So we have to commit with this one. We can frequently use this one, but we will forget about the prohibited list of abbreviation. So number 1, we have to ensure the verbal and telephone order according what we discussed before. Number 2, we have to commit with the list of approved abbreviation and forget about the prohibited list of abbreviation. Number C is the critical test or panic values or the critical values. What are the panic values or critical values? it should be notified immediately, and the caregiver should write it in the medical record. It's some results, whatever, it's lab results or it's radiology results. When the people working on lab or on radiology department see it, they immediately inform or report to the physician or the ward or the nurse or the caregiver, health caregiver, consenting to it by the report, so they can take a fast action, waiting until the documented result will arrive to the department. I will give you one or two examples very fast. For example, if in lab the calcium level is lower than 1.5 or more than 3 millimole per liter, so the lab have to endorse it very fast to the unit so the physician can take some action because it's endangering the patient life. The lab shouldn't wait until they send the result to the department through official letter or through a system if it's taking time. And the lab have to have a register or logbook for panic values, and also the department have to have a logbook for them, and they have to sign the type of the test, the time of sending the result, and the time for receiving the panic value reporting from it. Another example is glucose, if it's less than 2.2 or more than 30 millimole per liter. Another example is magnesium, if less than 0.35 or more than 1.5 millimole per liter, or if the potassium is less than 2.5 or more than 6 millimole per liter, and if the prothrombin time is less than 30 seconds, if it's more than 30 seconds, we have to endorse to the treating physician. So it's another way of communication. Number 3, to improve effective communication is to implement the critical test result policy inside the hospital, as we mentioned right now. At last, number D is the handover technique. Handover means remove your hands, and because I will receive the case from you. We will do it when we are delivering patient from department, like ED, like radiology, like physical therapy, or during changing the shifts between physicians and nurses, or there is a break relief, or when we are transferring the patient from one unit to one unit. Okay? We will do something. We have to know that it's simply talk to me. Hand-off technique or SPAR is simply talk to me, tell me what's happening. It's not good to come in the morning to receive your shift and the one who's spending all the night to tell you good morning, have a good day, bye-bye. No, he have to endorse to you on an official paper all the cases you have to receive from him. So you have to complete after what he started. Don't start from zero again. We will do this once through the SPAR or ISPAR. Some healthcare institutes will say ISPAR and some will say it's SPAR. My recommendation is SPAR, not ISPAR, but I will offer it to you. I for introduction, smooth, easy communication between the two healthcare giver. S for situation, tell him the patient situation before and right now. He came on a road traffic accident, he lost around 2 units of blood. We ordered the blood, his blood was like this. We offered him on ortho people, they are preparing him for internal fixation and so on. B, background, circumstances leading to this condition and history. Don't forget to tell him that take care the patient is allergic, for example, to some kind of medication, and if he has past history of hypertension, cardiac case, something like this. A for assessment, what is the investigation you did? What's your opinion? What's your diagnosis for this case? And R at last for recommendation, what's your opinion? What you are recommending to do? Okay, this is SPAR and it have a special form we are using inside the healthcare institutes. So now we finished the first 2 goals. Number 1 is identify patient correctly, and 2, improve effective communication among healthcare giver. Let's go for goal 3, improve the safety of high alert medications. So what's high alert medication at the start? It's defined as drug that bears a heightened risk of causing significant patient harm when we are using them in a wrong way. It could be wrong dose, wrong route, wrong time, wrong frequency. If we give this medication to the patient by mistake, it can burden, it can affect his life. It can cause a big harm to him. So we have to take care for those high alert medication or high risk medication. How we can do it? By a few recommendations. We will discuss them. Number one, label all medication, high risk medication, of course, of high alert medication or medication container. Put a tag on them. This is high risk medication. Two, keep high risk medication in a separate place in your pharmacy or in a nurse room. If they have a separate cabinet for high risk medication, keep it separate and put a tag on it that this is high risk medication. Do not put high risk medication in the pharmacy among other medications. And even in the nurse, in the medication room, in the nursing station, do not put it with other medication. Three, remove all concentrated electrolytes like potassium chloride, potassium phosphate, sodium chloride with high concentration more than 0.9% and the others from patient care area. Don't put dextrose 5% with dextrose 50% or 20% or greater in the same shelf. It's a crime because if the patient, if the sister or the nurse are heavily working, they have a lot of job to do, maybe they will take the dextrose with high concentration instead of the low concentration, giving it to the patient. So concentrated electrolyte should be removed from patient care areas. Should be kept under supervision and the control of the pharmacy, even if it's not in the pharmacy, it's in the medication room, in the nursing station. We have to supervise them as a pharmacist. It should be under our supervision. Use double check technique while administering. Never give a high alert medication to a patient without a double check. Double check by two nurses, double check by a nurse and the pharmacist, double check by a nurse and the physician. It should be two health caregiver, so inshallah the mistake cannot happen. And restrict their prescription for a few concerned staff. High alert medication should be prescribed only by a qualified staff according to their privileges. Okay. Number three, again, improve the safety of high alert medication. I'll show you some examples of high alert medication. Anesthesia medication like propofol and ketamine. Anti-arrhythmia like lidocaine, amiodarone, digoxin. It's high alert medication. We have to implement all the recommendation in the last slide before this or previous slide with all those medication. And this only one example from a list from high alert medication in one hospital. Dextrose, hypertonic solutions greater than 20% or greater, dialysis solution, epidural intrathecal drugs, hypoglycemic drugs, positive inotropes, moderate sedation agent, narcotic, neuromuscular blocking agents, and so on. All those medication are high alert medication. We have to tag them. We have to keep them in separate areas. We have to do double check before giving them. Pharmacy supervise them and should be prescribed only by a privileged health caregiver. Look at here in the shelf. We have to tag them, as you see with red, that it's high medication. And this is the double check. Never give, never administer to a patient without double checking by two health caregiver. Goal number 4, ensure correct site, correct procedure, and the correct patient surgery. It's a very important one. And I have to mention one very important thing. Almost all hospitals are implementing this one in OR, but it's required to be done in every unit inside the healthcare facility, implementing high-risk procedure. So it's for surgery and high-risk procedure. Like if we said that we are inserting a central line. If you're putting a central line, it's a high invasive procedure. So we have to implement this checklist for it. Let's discuss it now. If we want to give or make the correct surgery or correct maneuver or correct procedure to the correct patient, we have to follow up those instructions. Number 1, make sure that the correct surgery is done on the correct patient and the correct place on the patient body. So number one, patient identification. Number two, mark the correct place on the patient body where the surgery is to be done or the invasive procedure. So number one, identify the patient correctly. Number two, you have to make the marking site. We will discuss now how to do the marking site. Number three, pause before the surgery to make sure that mistake will not be happen. We have to take time out. We will discuss them now. Number one, so let's mention the four things before doing it. Number one, mark the procedure site. Number two, sign in. Number two, time out. And number four, sign out. Let's discuss in detail. Number one, marking the site, the procedure site. How to mark, when to mark, who will. This is our next slide. Marking the procedure site. Identify those procedures that require marking of the incision or insertion site. At a minimum, sites are marked when there is more than one possible location. We said that if it's bilateral, if the patient have two of them, we have to mark. For example, right ear, left right kidney, right foot, right leg, right hand, left hand, and so on. Anything the patient have two of them, we have to do the marking side. Okay? Number two, mark the procedure site before the procedure is performed, and if possible, with the patient involved. We have to do it while the patient is awake if we can do it, so the patient can help. For example, if we are marking the left foot and the patient can tell, wait, sir, you told me that you're going to make surgery in my left. So that time you can correct yourself. So it's possible to do it, or it's better to implement it while the patient is involved. Three, the procedure site is marked by licensed independent practitioner who is ultimately accountable for the procedure and will be present during the procedure. So the physician who will do the surgery, he should be the one who will do the marking site, not any other one. He cannot, for example, delegate the nurse to do it. No, it should be done by himself. Four, the method of marking site should be consistently throughout the hospital. It should not be unambiguous. Okay, so we will not use more than one marking site in the hospital. Some people will do it circle, someone will do it with the right mark, with the X mark, with the star. No, it should be one throughout the hospital. Every single healthcare giver should know that the marking site inside hospital is like this and should be mentioned in the. Number two, we will do the sign in. Sign in means the patient between the OR and between the ward. What will happen? I will explain now. This is what we are implementing in the hospital here. It's one form. We are implementing sign in, time out, and sign out in the same form. Simple. It's a very simple form like this. On the left side, you will find sign in. Sign in the holding area. The patient to confirm his identity, correct patient identification, the type of the procedure, consent is done already, the general consent and the special consent for the maneuver or the procedure. There is surgical site marked, yes or not applicable. Sometimes it's not applicable. Is the anesthesia machine and the medication check complete or not? Does the patient have an allergy or not? Difficult airway aspiration, known things or not? Risk of blood loss, yes or not? If all this is yes, everything is all right, then we can push the patient now to the holding area inside the, from holding area inside the OR right now. If no, one of them is no, we have to bring patient back until we complete all the checklist. So this is number two, sign in. So again, number one, marking the procedure site. Two, in the holding area, use the sign in checklist. Now the patient is about to do the surgery. He is in the OR now. He is on his bed right now. We will do the time out. Time out means hold, stop. We will not start our procedure. It's operation or high-risk procedure, we will not do it until we answer those questions. So it should be done before the surgical intervention or before the skin incision by a team of nurse, most concerned physician, anesthesia, okay, and technicians if they are there. We have to ask ourselves some question. Number one, surgeon, anesthetist, specialist, and registered practitioner verbally confirm what's the patient name. So again, patient identification. And what is the procedure plan to be done? Then the anticipated by surgeon, expected duration for the surgery, how much blood loss is anticipated, there is any specific equipment or a special investigation, yes or no, are there any critical or unexpected steps you want to team to know about? Anesthesia have to give his input. Are there is any patient specific concern? What's the ASA grade for him, anesthesia grade, and what monitoring equipment and other specific level of support are required for blood to be taken. And now the nurse have to do his part. Has the sterility of the instrument have been there and the instrument count is there or not? If all are yes, now we have to start Bismillah skin incision and do it. Of course, there is surgical site infection done, antibiotic prophylaxis before 60 minutes of the surgery, patient warming, hair removal, glycemic control. He's taking the prophylaxis for VTEs, essential imaging displayed or not. If it's all complete, now we can start our operation. Now we finished the time out. Let's go for sign out, which is the right side of the screen. Before the patient leaving the OR, we have to ask ourselves some question. If it's yes, we can send the patient now to recovery, then to the ward. If no, patient have to stay inside the OR. So what are the questions we have to go to? The registered nurse verbally confirm with the team. Has the name of the procedure is correct done or not? Has been confirmed that the instrument counts are not. It's good, it's right number before the surgery, or we forgot something inside the patient abdomen or inside the patient wound. Have the specimen be taken and labeled before sending it to the histopathology study or not? Have any equipment problem have been identified or not? Then signature. Now our patient can go throughout the OR or the invasive procedure safely. So this is the sign out and sign out. Time out, as we said before, we have to hold for skin incision. This is again the sign out. Now we finished the four things in this one, which is marking site, sign in, time out, and sign out. And it was the International Patient Safety Goal number 4 finished. Let's go to number 5. In my opinion, this is the most important one through them. It's my special concern, because almost in every single institute I worked, when the surveyor come from accreditation body, they will ask you by number, this one by number, what is goal number 5? And of course, the most important two international patient safety goals will take the concern from the surveyor and from healthcare givers is number 1 and number 5. Patient identification, all of us have to make sure it's done perfectly. Of course, all the 6, but we have to give special concern to 1 and 5. 1, identification, and the 5 is reduce the risk of healthcare associated infection. The most effective way is to hand hygiene, hand wash. All the studies said that if you are implementing a very good hand wash, you are implementing a very good long way through reduce the risk of healthcare associated infection. So if anyone is asking you what's the most effective way in reducing healthcare associated infection in a healthcare institute, you have to answer hand wash. So what's hand wash and what's hand hygiene? Hand hygiene is the big thing. Hand wash is just washing the hand. So what's hand hygiene? It's hand washing, putting gloves, keeping nail short, not using the nail polish, removing the rings, removing the watches, removing the jewelries. It's all hand hygiene. So let's go through goal number 5. We have to commit with 4 things again: hand wash, waste management, isolation, and PPE. We'll discuss them one by one. Let's start with hand wash. As you know, it's number 1, complying with current CDC recommendation for hand hygiene. When we have to wash our hands, the 5 moments. Again, the 5 moments. You have to know them very well. You have to implement them very well. People of quality, risk management, patient safety, infection control have to monitor it throughout the healthcare institute. Number 1, we have to wash our hands before patient contact. Number 2, before a septic task. Number 3, after body fluid exposure risk. Number 4, after patient contact. And number 5, after contact with the patient surrounds. So simply, it's 2 before and 3 after. Before patient contact, before doing any procedure to the patient, and after aseptic, and after body fluid touching, after patient contact, and after patient surrounding touching or contacting. So this is number 1, washing. How to wash the hand? It's very simple, and it's explained to all of us by people of infection control. You have to wet your hand, both the substance you are going to wash with, then palm to palm, palm to hand, in between and around the fingers, tips of the fingers, big thumb and wrist, then it is done. Number 2, waste management. So simply, we will not go deep through things of infection control. We will mention it simply. How to do our waste management, put every waste inside the healthcare facility in the specialized container for it. For example, we will put the sharp objects in the sharps. For example, the needle, the scalpel, we will put it on the sharps. We will use the yellow bags for infectious waste. Cotton tagged with blood, with pus, everything like this, we will put it because it's infectious. We have to put it in the yellow bag. Red bag, we will put the human parts, placenta, amputated parts. We will put it inside the red bag. And of course, the black bag, and sometimes people will put it in a white bag. It's the ordinary waste. Some surveyor will come to ask you where you have to put the paper for sandwich. You have to tell them, of course, the black bag. Number 3, isolation practice. So for the isolation practice, very fast, we have to have the isolation room as the guidelines. And number 2, we have to use the isolation cards and the isolation tags. Tags on the doors and the cards while we are moving the patient from one place to one place. As you know that we have 3 isolation cards here. The green one for contact percussions, and the yellow one for droplet percussions, and the yellow one for airborne percussions. So isolate the patient who have high risk of spreading the infection in the special room, in the isolation room, which of course should be a negative pressure room, and use the isolation tags and isolation cards. This is very simply about isolation. Number 4 now is the PPE, personal protective equipments. Do not do any procedure, do not consult a patient, do not do any procedure without putting your PPE. So here simply we will explain very fast how to remove the sequence of the PPE. Number 1, if you are putting on, you have to wash your hands. Then you have to wash, after washing hands, you have to put mask, goggles, and at last you have to put your gloves. So your gloves now is clean, because I saw some stop putting the gloves at start, then they will put the gown mask. So now the gloves would be contaminated. So the glove should be at last. When you are trying to put them off, start with the gloves because it's contaminated now after the procedure. So remove your gloves, then the gown, then the glasses, then the mask, then you have to go to wash your hands. Now let's go for the last international patient safety goal. Number 6 is reduce the risk of patient harm resulting from falls. It's a very, very important one, and it's a simple goal. Let's discuss it in details. Number one, in your facility, you have to adopt a fall reduction program and evaluate its effectiveness while you are implementing it. Like I think we have Brandon and Morse, but Morse is widely used right now. Two, nurses have to respond quickly to all patient call or alarm. The patient to call, the nurse have to go to him directly to help. Maybe he is about to fall down, so we have to prevent his fall before falling. Educate patient and families about the danger of falls. Sir, you can fall down, you have to do like this and like this and like this. So healthcare education should be done for patients regarding falls. Recognize the patient whom at risk to fall, like old age patient, patient with gaits, kids. You have to recognize them and you have to monitoring them. Keep your eyes on them. You have to use low bed rails or side rails or bed alarms because they can fall down. So we have to use only low beds, not high one, and bed alarm when possible. Use bed with side rails for pedia and restrain patient if it's needed or ordered by the physician. If we are implementing all of this, we can reduce the patient fall. All of this will be done on a form. This form is assessment, and we have to do reassessment every shift or every day according to your hospital or facility policy. If you are doing it and you are watching your patient, inshallah, they will not fall down. Now we 6 international patient safety goals. This is the Morse scale, and this is the side rails up, and this is patient restraint if it's needed. If we are afraid that the patient can hurt himself and fall down, we can restrain him according to the patient hospital policy. Very simple idea from me. We did this one in one hostel and they succeeded too much. Make it as a small card and give it to all health caregiver. Though they can hang it over their pockets with the ID card so they can read it frequently. They can keep it in mind and implement it. And if they have any question, they can go back to it to remind it. Any question? I finished all the 6 international patient safety goals. Hope it's clear to you, and inshallah we can meet in another presentation very soon. Before we can finish it, I made a small test. It's like a pass test. You can answer it, so you can estimate what the benefits you got